Welcome to the GMJ podcast, the official podcast of the Georgian Medical Journal.
In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy.
This episode reviews the article titled The 2026 Message from Yohei Sasakawa, WHO Goodwill Ambassador for Leprosy Elimination.
And to properly structure the episode, we will be covering the central research question or thesis, followed by the conceptual framework and background.
Right, and then we'll move into the core findings or analytical argument, the structural or methodological considerations, and the institutional and policy implications.
Before finishing up with a system-level reflection and a structured conclusion encouraging consultation of the full article.
Exactly. So to jump right into that central thesis, I want you to imagine a disease that was essentially cured decades ago.
A true medical triumph.
Yes, the kind of epidemiological breakthrough that really should be written about in history books as a decisively closed chapter. But I want you to consider that despite this cure, this exact same disease continues to systematically destroy lives today.
And the destruction isn't primarily medical, is it?
No, it's not. It is profoundly social. It completely dismantles the fabric of a person's existence long after the bacteria has been cleared from their system. It presents this stark contradiction, a condition that is medically solved but remains a profound human tragedy.
Which challenges our fundamental assumptions about how progress operates in global health.
Mm-hmm.
We tend to operate under this paradigm that once science engineers a cure, the societal problem simply evaporates.
Right, the magic bullet theory.
Exactly. But human society, burdened by historical precedents, is rarely that straightforward.
Yeah.
The pharmacological solution is often just the first step in a much longer, much more complex structural battle.
That is precisely what we are going to explore in this deep dive. We are looking at a highly detailed stack of notes centered around this 2026 message from Yohei Sasakawa,
The World Health Organization's Goodwill Ambassador for Leprosy Elimination.
Yes. And his message, which was released for World Leprosy Day, is particularly notable because this year marks the 25th anniversary of his appointment to this specific role.
A quarter century dedicated to unpacking the modern reality of leprosy, or Hansen's disease.
Our objective today is to dissect how a definitive medical victory from the 1980s has somehow failed to resolve a human rights crisis that has been thoroughly entrenched for 2,000 years.
We really should begin by establishing the conceptual framework and background of that medical victory because the epidemiological data is quite striking.
It really is. Back in the mid-1980s, global health organizations were tracking more than 5 million cases of leprosy worldwide.
And that prevalence rate represented a staggering burden on the global healthcare infrastructure. The shift that occurred next is honestly one of the most significant moments in modern pharmacology.
You're talking about the introduction of MDT.
Yes, in 1981, the WHO recommended multidrug therapy, or MDT. Prior to this, treatments often relied on monotherapy, primarily a drug called dapsone.
And monotherapy usually leads to issues with resistance, right?
Exactly. The Mycobacterium leprae bacteria was rapidly developing resistance to dapsone. MDT changed the entire landscape by combining dapsone with rifampicin and clofazimine.
A cocktail approach.
A highly effective one. It not only prevented antibiotic resistance, but it effectively killed the pathogen. It rendered the patient non-infectious within just a few days of starting treatment.
The statistical impact of that protocol simply cannot be overstated. According to the source data, by 2024, the number of reported cases had plummeted from over 5 million down to 172,717.
Spread across 133 countries.
Right. If you plot that on a graph, it looks like an unmitigated public health victory. However, Sasakawa's message is fundamentally a warning against complacency.
Because when we analyze the core findings, the granular data within those 2024 numbers, two specific metrics immediately surface as indicators of a failing system.
Let's get into those metrics. What's the first one?
The first critical metric is that out of those roughly 172,000 cases, 5.4% were children under the age of 15.
That's a significant red flag.
It is. And the second is that 5.3% of the total cases were classified as presenting with grade 2 disability.
We should probably break down the clinical reality of a grade 2 disability in the context of Hansen's disease so you understand exactly what we're talking about. We aren't just talking about a mild impairment here.
Not at all. Hansen's disease primarily affects the skin and the peripheral nerves.
And when the bacteria infiltrates the nervous system, it causes a severe loss of sensation. The visible physical damage often associated with the disease, the loss of digits, the severe ulcerations.
It isn't typically caused by the bacteria actively destroying the tissue. That's a common misconception.
Right, it is a secondary effect. Because patients lose the ability to feel pain, they sustain repeated, unnoticed injuries to their hands and feet.
Which leads to severe infections and the eventual reabsorption of cartilage and bone. It can also lead to blindness if the nerves controlling the blinking reflex are damaged.
That physiological context is absolutely crucial for understanding why that 5.3% figure is so alarming.
Exactly. Multidrug therapy is highly effective, but its primary function is to halt the progression of the disease. It cannot reverse profound nerve damage once it has occurred.
Therefore, a 5.3% rate of grade 2 disability points directly to a systemic delay in diagnosis.
It means that thousands of individuals are living with the disease, entirely untreated, for years before ever entering the healthcare system.
And if the WHO is distributing multidrug therapy globally and it has been provided free of charge since 1995, a 5.3% severe disability rate initially looks like a supply chain failure.
You might assume the drugs simply aren't reaching rural or marginalized clinics.
But the accompanying statistic regarding children suggests the bottleneck isn't the supply chain at all. It's that patients are actively remaining outside the reach of the clinics.
Right, because Mycobacterium leprae is a notoriously slow-growing bacillus. The incubation period can last anywhere from 5 to 20 years.
So if over 5% of new cases are appearing in young children, it proves the chain of infection is highly active.
They are being exposed to untreated individuals within their immediate environments right now.
Which brings us to the analytical argument of Sasakawa's observations. The medical data shows a failure of reach, but his 25 years on the ground indicate a much darker reason for why those individuals remain out of reach.
It isn't a logistical oversight. It is active social exclusion. People are delaying seeking treatment or actively hiding their symptoms out of an intense fear of the societal repercussions of a diagnosis.
He states quite clearly that the social stigma attached to leprosy is often more problematic and destructive than the pathophysiology of the disease itself.
That forces us to confront the historical persistence of this stigma. The source material emphasizes that leprosy is one of the oldest known infectious diseases.
It's explicitly mentioned in ancient texts and scriptures, including the Bible.
We are dealing with prejudices that have been compounding for millennia. It is worth comparing this to the societal reactions we saw during the early days of the HIV/AIDS epidemic.
Or historically with tuberculosis. Society has a well-documented pattern of ostracizing those with visible, poorly understood illnesses.
But the stigma surrounding Hansen's disease has a 2,000-year head start. It is woven into the very linguistics of exclusion.
The linguistic aspect is fascinating. The term leper itself evolved from a medical descriptor into a universal metaphor for an outcast.
Sasakawa raises a deeply philosophical question in his message regarding this. He hypothesizes whether the very concept of systemic discrimination in human society originated from the primal fear of this specific disease.
Did the fear of these visible impairments become so deeply ingrained in ancient cultures that it established the architectural blueprint for how human societies marginalize the other?
It is a profound proposition. If the earliest systemic codification of exclusion was based on the physical manifestations of Hansen's disease, it explains why the prejudice is practically calcified into modern cultural frameworks.
And we see the devastating impact of that calcified prejudice today, operating completely independent of the medical reality. This brings us to the structural and methodological considerations.
Because the source material outlines how individuals who have successfully completed multidrug therapy,
People who are 100% medically cured.
yes, biologically incapable of transmitting the bacteria, they still face unending social exclusion.
The medical chart reflects a cure, but society reacts to the residual physical scars with an ancient, irrational fear.
This is where the delay in diagnosis we discussed earlier creates a permanent societal trap. For the 5.3% who delayed treatment until they developed grade 2 disabilities, the cure does not erase the visible markers of the disease.
Consequently, the social exclusion they face is systemic and absolute. The source provides specific operational examples of this exclusion, and it goes far beyond interpersonal prejudice.
It is highly institutionalized.
The institutionalization of the stigma is perhaps the most striking element of the report. We are looking at legal and economic ruin. The text highlights forced divorce as a primary consequence.
In several nations, antiquated legal frameworks still exist that allow for the dissolution of a marriage solely based on a leprosy diagnosis.
Regardless of whether the patient has been cured.
We also see the systemic denial of educational opportunities, where academic institutions refuse admission to cured individuals.
Or even their children. And predictably, this extends to unfair dismissal from employment, which completely severs their economic lifelines.
It is the systemic dismantling of an individual's agency. And what must be emphasized is that none of this exclusionary architecture is justified by modern epidemiology.
Or public health protocols. It is entirely sustained by inherited irrational fear.
The individual is forced to endure what Sasakawa terms the unending pain of social exclusion, isolated from their community despite presenting zero public health risk.
That level of isolation fundamentally alters how the global community must approach the issue, moving us into the institutional and policy implications.
Because distributing blister packs of antibiotics is insufficient when the primary barrier to eradication is sociological.
You cannot cure a structural prejudice with a pharmacological intervention. This realization catalyzed a significant shift in international strategy.
According to the source, in 2010, the United Nations General Assembly took what is described as a historic step forward.
They unanimously passed a resolution aimed at eliminating discrimination against persons affected by leprosy and their family members.
The importance of that 2010 UN resolution lies in its reclassification of the disease. By officially defining the stigma surrounding Hansen's disease as a human rights violation, the UN shifted the framework of accountability,
It moved the burden of care beyond the purview of doctors and medical NGOs.
placing it squarely on the shoulders of governments, legal systems, and civil society. A unanimous UN resolution dictates that protecting these individuals from forced divorce, educational bans, and economic disenfranchisement is a sovereign obligation.
Not merely a medical charity initiative. However, the geopolitical reality over the subsequent decade reveals a concerning trend.
Despite the unanimous declaration in 2010, Sasakawa notes that international interest in political will have notably waned in recent years.
This brings us to a well-documented phenomenon in global health administration, the paradox of success. As we established, the global case numbers plummeted from 5 million to roughly 172,000.
And when health ministries and international funding bodies review those epidemiological spreadsheets, the sharp downward trajectory often prompts them to declare a premature victory.
It is the last-mile epidemiological challenge. Resources and attention are inevitably diverted to more acute, rapidly spreading crises.
Like novel viral pandemics, the urgency surrounding leprosy dissipates because the overarching statistical curve looks favorable.
Yet, as we've analyzed, those aggregate numbers obscure the ongoing human rights violations.
And the localized chains of transmission indicated by those pediatric infection rates. The international community effectively packed up the infrastructure while the underlying sociological fires were still burning.
Sasakawa makes a compelling argument regarding how we evaluate progress in this arena. Success against a deeply stigmatized disease cannot be measured exclusively by the reduction in bacterial transmission.
It must be evaluated holistically, looking at the lived reality of the affected demographic.
Which leads us to our system-level reflection. The epidemiological profile of who contracts Hansen's disease today is inextricable from severe poverty.
Because these individuals are systematically excluded from education and the formal labor market, they are pushed to the absolute margins of society.
And that marginalization introduces another critical layer to the crisis, one that the source text explicitly highlights: the intersection of neglected tropical diseases and climate change.
Sasakawa draws a direct line between the medical stigma of Hansen's disease and heightened climate vulnerability. It serves as a classic threat multiplier scenario.
Let's explore that threat multiplier dynamic, because the connection between a bacterial infection and extreme weather isn't immediately intuitive to most people.
The vulnerability stems from the economic disenfranchisement we just discussed. When individuals are pushed out of traditional societal safety nets and forced into extreme poverty due to stigma, they often end up in substandard housing.
Usually in ecologically fragile areas.
Precisely. So when climate change drives extreme weather events, be it severe flooding, prolonged droughts, or coastal erosion, these marginalized populations are hit first.
And they entirely lack the capital to recover or relocate.
Furthermore, the logistical disruptions caused by climate change directly impact disease management.
Right, because multidrug therapy requires a strict, continuous regimen spanning 6 to 12 months.
When an extreme weather event displaces a community, that supply chain is severed. For an undocumented or heavily stigmatized individual who has been displaced as a climate refugee, accessing a new clinic to resume treatment is incredibly fraught.
They risk exposing their medical history to a new population.
potentially facing the exact same ostracization that displaced them initially.
Additionally, climate-driven resource scarcity often forces populations into denser, unsanitary living conditions.
Which creates the optimal environment for the localized transmission of Mycobacterium leprae, further explaining those pediatric infection rates we saw.
The compounding nature of these crises is staggering. The ancient prejudice enforces the poverty dictates the geographical vulnerability, and the resulting climate displacement fuels the continued transmission of the disease.
It ceases to be an isolated medical issue and reveals itself as a profound failure of structural equality.
This is why Sasakawa insists that the ultimate goal must align with the United Nations Sustainable Development Goals.
The foundational ethos of the Sustainable Development Goals is the pledge to leave no one behind. Achieving that in the context of Hansen's disease requires a paradigm shift.
It is impossible to fulfill that pledge if the global community actively ignores a demographic subjected to structural discrimination.
The SDGs demand that we prioritize the most marginalized populations. That means actively dismantling the legal and social frameworks that permit this 2,000-year-old prejudice to persist.
It requires ensuring that every affected individual is recognized and afforded basic human dignity alongside their medical treatment.
Recognized and afforded basic human dignity. That phrasing cuts to the core of Sasakawa's 25-year mission.
It serves as a potent reminder that global health logistics, the manufacturing of pharmaceuticals, and the deployment of field clinics are only half the equation.
The more formidable challenge lies in auditing how a society treats its most vulnerable demographics.
The scientific community successfully engineered a cure for the biological pathogen decades ago, but the responsibility to engineer a cure for the sociological pathogen rests entirely on the broader society.
It forces a necessary confrontation with the irrationality embedded within human institutions. We are highly capable of accepting scientific advancements, yet we simultaneously harbor cultural reflexes that actively defy those very facts.
The persistence of this particular stigma offers a highly revealing lens through which to examine our own societal structures. We began this discussion by considering the contradiction of a disease that is biologically cured but socially fatal.
Having unpacked the clinical realities of multidrug therapy, the deep historical roots of the prejudice, and the modern systemic failures that sustain it, we are left with a sobering perspective on human behavior.
It requires us to apply this analytical framework beyond the specific parameters of Hansen's disease.
The methodology of exclusion we've discussed here, the utilization of fear to justify systemic disenfranchisement, is rarely isolated to a single issue.
That leads directly to the structured conclusion and the final thought we want to leave you to ponder on your own. Based on the historical and epidemiological context we've just analyzed, consider the broader implications.
If a prejudice forged 2,000 years ago can successfully circumvent modern medical science, effectively ruining lives long after a definitive cure has been universally distributed,
What other deeply ingrained societal fields are we currently operating under that possess absolutely no factual or scientific basis? What other invisible walls of prejudice have we normalized, and who is currently trapped behind them?
it is a critical question for evaluating our modern institutions.
Thank you for listening to the GMJ podcast.
For a full and detailed discussion of the topic presented in this episode, we invite you to consult the original article published in the Georgian Medical Journal. A direct link is provided in the episode description.
We look forward to continuing these scholarly discussions in future episodes.